Good morning. Thank you for having me. I'll be talking about chronic impulsive aggression here. I do have some financial disclosures. I do some work for Medicaid therapy management projects, ACA, and drug investigational trials, mostly for Tourette's, autism, and ADHD. All medications discussed will be off-label, as there's no medications approved for a disruptive behavior disorder. Some of the research. Again, we'll be talking about more of a reactive aggression. Risk factors are inconsistent, harsh discipline, parental discord, and gene factors. It's important to do comprehensive assessment and scales and treat comorbid conditions. We have already some therapies, parent management training, behavioral therapy, CBT. Berkey and all conducted more studies on CBT, social skills, interpersonal psychotherapy, parent-focused therapy, and classroom interventions. Here are some a list of therapy treatments. Want to add neighborhood green space has been used, multimodal interventions, adaptations of PCIT that are more 8 weeks and in a group session. And then also adding life skills. Most evidence right now is for methylphenidate, and then for antipsychotics is for risperidone. This is the TOSCA trial. We have the 9-week trial where we looked at PCIT, stimulant, and placebo, and parent training, stimulant risperidone. And both groups showed improvement, and the one with the risperidone showed moderate improvement with some side effects, which included weight gain and prolactin elevation. With regards to 12-month follow-up, there was just slight improvement in the ones that used risperidone versus the ones that did not. Again, most evidence for risperidone. So the trend is basically there's moderate benefit with short-term use, but there is potential weight gain and prolactin elevations. Limited data for under 5, and really a lot of limitation of evidence for other atypicals. This is a global problem. There's a study in Iran. They looked at aripiprazole and risperidone and found benefit initially, even at low doses. So there was no really any evidence for using higher doses or longer treatments. It's a global problem, not only here, but in Canada, Australia, Germany. So even with universal healthcare systems, kids are being treated with atypicals for disruptive behaviors, depression, and anxiety. And only in Canada, 20% were receiving actually monitoring labs. The age group for risk is really adolescents that are developmentally delayed, male with aggressive behaviors. We're not using long-acting IMs for disruptive behaviors, but there are some other studies looking at safety and efficacy in pediatric populations right now. The level of evidence right now that we use is from A to D. This is really extrapolated from ADHD study, ASD studies, and A through D do not reflect the quality or organization or of the studies, so or how recent the studies really are. Some of the changes I propose is maybe moving up the methylphenidate with the level of evidence due to the recent trials in the disruptive and ADHD subgroup, leaving atomoxetine the same, all the other ones the same. Lorazepam, moving it to D because there are some approval for pediatric population now in schizophrenia and bipolar disorder. But it's important to note that there is a 6-week randomized trial that showed to be a negative trial. There was no statistical significance in treating irritability associated with ASD. So these are some other treatments that some may use that might be helpful. A lot of controversy regarding omega-3 and iron deficiency, but might be helpful and pretty benign treatment. There's no data on the newer antipsychotics, but I listed them there for you. So the bottom line is that there's a lot more research with regards to therapies, including social skills, getting schools involved. When using psychotropic medications, using it more short-term. Long-term, you run into more side effects, and it's a chronic problem. So really utilizing those community services is the way to go. Looking more aggressively at treating the ADHD using the methylphenidate stimulants.
Okay, thank you very much. We appreciate it.